Hello, this is Dr. Maimuna. So, very good evening to all of you. Today we are discussing a recent topic on the management of ovarian carcinoma in pregnancy. This is a recent article publishing this. So, just let me tell you that. Let me share you. Okay, can you see the screen? Yes. Let me tell you, my slides are very crisp. They don't contain so much of so much of matter. You can just write after this class. You can just write at least 10 to 15 points regarding this. Okay. So let us start with the topic proper. So, what is the management of ovarian carcinoma in pregnancy? The introduction is it is the second most common cancer. Okay, the ovarian cancer is the second most common cancer, and the first one is the cervical cancer. What is the incidence of adnexal masses? What is the incidence of adnexal masses during pregnancy? That is, it varies from 0.05 to 2.4%. Okay, it varies from 0.05 to 2.4%, and approximately 1 to 3% of these are malignant. Okay, so what is the most common ovarian malignancy in pregnancy? The most common ovarian malignancy in pregnancy is the germ cell malignancy, and which is followed by the sex cord stromal tumors, borderline tumors, and lastly the invasive epithelial cancer. So what happens in the pregnancy is the borderline tumors will have aggressive histological features. Okay, the borderline tumors will be having aggressive histological features. Usually the borderline tumors will be non-invasive, and they will be having very calm composed in cases of the other women. But in pregnancy, they will be having the aggressive histological features. But all the ovarian tumors will be having a very good prognosis in the pregnancy. Okay, so I'm going fast because I need to cover so much. If you find any difficulty while I'm teaching, you can please let me know. Okay, so what is the survival rate of the ovarian cancers in pregnancy is the 5-year survival rate will be around 72 to 90%. Okay, so that itself shows that it is having a very good prognosis and the survival rate is pretty good. So how to diagnose the ovarian cancer in the pregnancy? The first thing you can see about signs and symptoms. Okay, how the patient presents you can see with the signs and symptoms. And the second thing is by the different investigations. Okay, so it is very difficult to diagnose in pregnancy. Why? Because the ovarian carcinoma or the ovarian tumors will be having signs and symptoms of vomiting, pain abdomen, okay, and then enlargement of the tummy. So these are the things you will be having in the ovarian carcinoma. The same things you will be having in the pregnancy also. In the pregnancy also, you will be having vomiting, you will be having slight pain abdomen, and you will be having the enlargement of the tummy, which will be making the diagnosis very difficult, and at very late stages you will be diagnosing the pregnancy, diagnosing the ovarian tumor in pregnancy. Okay, so what is the most common symptom? The most common symptom here would be pain. Okay, so pain would be the most common symptom. Here you can see pain would be the most common symptom here. Okay, so whenever a pregnant lady comes with a repeated complaint of pain, you can just keep this in consideration. Okay, so what are the investigations that help in the management, that help in the diagnosis of ovarian carcinoma in pregnancy? The first one is the ultrasound, and the second is the MRI. And the routine use of prenatal ultrasonography, this increases the detection of asymptomatic adnexal masses during pregnancy. Here asymptomatic is important. So whenever a pregnant woman does not have any kind of symptoms of ovarian tumor, but you will be having a prenatal ultrasonography. So you will be having an ultrasound of the pregnant women routinely, like an early OB scan. So usually in early OB scan, you can have the detection of any adnexal masses if present. Okay, next comes the iota rules. So the iota rules you will be using in the normal ovarian tumors also to classify, and in the pregnancy also they can be used, and they are having a very good sensitivity of 92%. Okay, but if the malignancy is suspected, then use MRI. if you are suspecting a malignancy, you can use MRI. Otherwise, ultrasound, it is easier, and you can screen for the adnexal masses. But if you suspect a malignancy, then use MRI. Okay. So what about MRI? Okay. If you suspect a malignancy, then yes. So in MRI, you cannot use gadolinium MRI. You cannot use gadolinium MRI. This is contraindicated in pregnancy. And if you suspect any nodal and distant metastasis, then you can use whole body diffusion weighted MRI, but not PET, but not 18 FDG PET. Only you can use whole body diffusion weighted MRI. Okay. So these are about the investigations, and the most important is the tumor markers. So what about tumor markers? Usually in cases of ovarian malignancies, you will be very happy to see about tumor markers. But here, what happens? So the several markers could be deranged in pregnancy. Usually most of the markers, these are the proteins that can be elevated in the pregnancy also. So let us see what happens. The CA125, this is actually very, very important. But what happens in the pregnancy? It increases in the first trimester, third trimester, and puerperium. The HCG, normally it increases in the pregnancy. And alpha fetoprotein, it also increases in the pregnancy. Let us see the most important things. Inhibin B and AMH. These things you will be seeing in the granulosa cell tumors. Okay, these things you will be seeing in the granulosa cell tumors. Okay, in the granulosa cell tumors, these are unaffected. So whenever there is a granulosa cell tumor, the inhibin B and AMH will be rising in cases of the pregnancy also. Then LDH. LDH also is unaffected in pregnancy unless otherwise it is a preeclamptic case. So in cases of preeclampsia, there will be increase in the LDH. Otherwise, if there is a dysgerminoma in pregnancy, you can happily use LDH. Okay. And coming to the human epididymal factor 4, it is seen in the epithelial ovarian cancer. This is also unaffected in pregnancy, so you can use happily. Then coming to carcinoembryogenic antigen, this increases only in the third trimester. Otherwise, you can use in the other 2 trimesters to detect any form of tumor. Okay. So just make a note of it. Inhibin B, AMH, LDH, and HE4. These are unaffected in the pregnancy. The rest will be increasing. Okay, don't worry. I will be sharing you the slides as well in the app. Don't worry. So coming to the management. So how do you manage the ovarian tumors or adnexal masses in the pregnancy? The first is the optimal management for ovarian tumors is surgery. So where you are doing it, you can have surgery at any point of time in the pregnancy if the mother is at risk. But the optimal time will be 16 to 20 weeks. Why? Why you are doing it at 16 to 20 weeks? Because the risk of miscarriage will be decreased. Okay, so if there is any problem of having a chromosomal anomaly baby, or if there is any something like APLA, so all these things you will be having the miscarriages before 16 weeks, so that the healthy baby will be there and the risk of miscarriage will be less, and the size of the uterus also allows the access. If you cross 8th month, 7th month, or 28 weeks, then the size of the uterus will be more, then you cannot have enough access. Okay, so that's why 16 to 20 weeks will be the optimal time, right? And the other reason is the hormonal dependence of the corpus luteum. So what happens? Whenever in the initial stages of the pregnancy, in the first trimester, the corpus luteum will be taking the action. So because of this corpus luteum, there will be presence of functional cysts, and these cysts can be mistaken with that of the ovarian tumors. So because of this, whenever it is after 12 weeks, the luteoplacental shift occurs and the corpus luteum will be replaced by placenta, so that the functional cyst will be resolved by this time. That is, by this 16 to 20 weeks, if there is any functional cyst, it will be resolved and you will not get confused with any of the ovarian tumors. Okay. So what form of surgery you can advise? It could be laparoscopy or it could be laparotomy. So what about laparoscopy? What are the prerequisites of laparoscopy? The prerequisites of laparoscopy is a tumor around 10 centimeters in size, and it should be confined to the ovary, and in-bag retrieval should be done. You cannot have a open removal, aggressive removal of the tumor, because it might have metastasis or it might have a spillage. So in-bag retrieval without spillage should be there, and expertise of the surgeon is to be present. So what are the advantages of choosing a laparoscopy? The advantages are, it is having a fewer fetal adverse effects, it will be having shorter operative time, and a less post-operative pain and bleeding. Okay, and there is a reduced risk of thromboembolism because she is having a shorter hospital stay. So she will be walking, she will be having early ambulation, and there will be reduced risk of thromboembolism. Okay, so this is about the advantages. So what are the guidelines of laparoscopy? So whenever you are performing a laparoscopy to the patient, it should be in an open method, and a low intra-abdominal pressure of 10 to 13 millimeters of mercury should be there, lasting no more than 90 to 120 minutes. Okay, it should not last for 90 to more than 90 to 120 minutes. And the trocar sheath should be placed by a experienced surgeon. Where it should be placed? It should be placed 3 to 4 centimeters above the uterine fundus. Okay, next comes to the laparotomy. If someone is planning for laparotomy, what are the advantages? There will be a better accessibility to the epigastric region and the pouch of Douglas, and ability to evaluate the retroperitoneal lymph nodes. So what is the staging procedure you can have in these ovarian tumors? In the ovarian tumors, you can have infrasonic omentectomy, appendectomy, pelvic peritoneal biopsy, and lymph node dissection. So these are the things where you can plan for a staging procedure. But what happens in the pregnancy is, you cannot access this pouch of Douglas very easily, because the uterus will be having a large area where it can cover the pouch of Douglas. So you have to plan a restaging in the postpartum. Okay, after delivery, you have to plan the restaging. Okay, so what is the timing of surgery? If there is a low risk of progression of the ovarian tumor, then postpone the surgery till delivery. And if there is a high risk of progression in the first trimester, if there is a high risk of progression, advise MTP. She cannot continue pregnancy because the pregnancy might worsen the prognosis of ovarian tumor. Okay, and then if they are going to continue the pregnancy, like in cases of low risk, if you are going to continue the pregnancy, a biopsy or an adnexectomy should be performed, and later post-delivery chemotherapy with platinum-based compounds and cytoreductive surgery can be planned. Okay, for those who are planning to continue the pregnancy, first a biopsy should be there. After delivery, you need to go for platinum-based chemotherapy, and then cytoreductive surgery can be planned. Now coming to the chemotherapy. So what is chemotherapy could not be given in the first trimester because there is a highest risk of teratogenicity at 4 to 10 weeks of gestation, and it is around 10 to 20%. So there is a highest risk of teratogenicity will be there, and this chemotherapy should not be recommended beyond 35 weeks of gestation. So whenever you are having a near to the top of the EDD, you cannot give this chemotherapy. Okay, this should not be recommended beyond 35 weeks of gestation, and at least a gap of 3 weeks should be there between the last course of chemotherapy and the delivery. Why? For the recovery of both fetal and maternal bone marrow. So if you are planning a delivery at 37 weeks or 38 weeks, at least 3 weeks before you have to stop, that is 35 weeks. You have to stop at 35 weeks. Okay, so this is chemotherapy. What form of chemotherapy you are using? So just keep in mind these 3 things. That's it. It's no elaborate discussion. Okay, so for epithelial cancer, you will be using paclitaxel and carboplatin. For germ cell tumors and the stomal cell tumors, the first line is weekly paclitaxel and carboplatin only, but the second line would be BEP regimen. Okay, the second line would be BEP regimen, and the targeted therapy should be avoided. Okay, you cannot give a targeted therapy in pregnancy. Only for epithelial cancers, you can go with paclitaxel and carboplatin. For germ cell tumors, you can go with weekly paclitaxel and carboplatin. Okay, the targeted therapy should be avoided. So, coming to the anti-angiogenic drugs, The bevacizumab and VEGF are teratogenic and induce IUGR, pregnancy loss and skeletal malformation. So you cannot use this bevacizumab and VEGF because they are teratogenic. Okay. Coming to the radiotherapy. The radiation therapy during pregnancy may cause fetal death, malformations, and stunted growth and childhood cancer. The radiation therapy during pregnancy may cause fetal death, malformations, stunted growth, and childhood cancer. Okay, that's why the radiotherapy you cannot use in pregnancy. Chemotherapy, it is contraindicated in the first trimester, but radiotherapy you cannot give it in pregnancy. Okay, so what is the outcome? The outcome is, sorry for the typo error, the outcome is surgery is having a good outcome than the combination treatment, that is with surgery plus chemotherapy or only chemo. So only surgery will be having a good outcome in the pregnancy than that of the combination treatment. So this is all about the management of ovarian cancer. But now, what is the obstetric management? What we are going to do with the baby? So you have to have a fetal monitoring before and after surgery, and the prophylactic use of tocolytics you can consider, and serial growth scans are to be done if chemo. So if you are using a chemotherapy, 2 to 4 weekly, you are planning a ultrasound. Okay. And what is the time of delivery? That is 37 weeks. You can recommend corticosteroids for the fetal lung maturity. So the chemotherapeutic drugs, that is taxanes and platinum based compounds, they have increased NICU admission and small for gestational age. So if the patient is using these two things before the delivery or in the pregnancy, then the neonate should be assessed for these conditions like small for gestational age, or if there is any need for NICU admission. Okay. And thromboprophylaxis, this is very, very important, because usually the pregnancy is a hypercoagulable state and everyone is at risk of clotting. But here, this is most important here, and the thromboprophylaxis should be given. Okay. So let me just revise this. Fetal monitoring should be there. Tocolytics you can consider. Growth scans are to be done 2 to 4 weekly. Time of delivery would be 37 weeks. Corticosteroids can be given. Taxanes and platinum based compounds will be having some fetal problems. So you should be cautious after the baby is born. Okay, so how to follow up? After the delivery, you can see if the placental metastasis is present, then the follow-up of the child should be up to 3 months. Okay, so after the vaginal delivery, when to start the chemotherapy or oncological treatment? As we have told, chemotherapy you should stop before 35 weeks. Then when to start? If it is a vaginal delivery, you can start immediately. But if it is a cesarean section, you just start after 1 week, because this 1 week she will not be having any ambulation, or there will be some decreased amount of fluid intake. So chemotherapy would be started after 1 week. If there is no chemo within 3 weeks, you can allow the breastfeeding. So there are many controversies regarding breastfeeding, but if she is not taking any chemotherapy now, or if the chemotherapy is later than 3 weeks, then the breastfeeding can be allowed. And if the patient is on chemotherapy, you have to do the hematology. LFT, RFT should be checked regularly. Regularly you have to check the hematology. Next, and check the neonate for SG and if there is any risk of preterm. And if the baby is exposed antenatally to the cisplatin or anthracycline, then you should have a long-term follow-up every 3 years. So every 3 years you should have a long-term follow-up to the child who is exposed to cisplatin or anthracycline. Okay, and what you have to do? You have to go for an auditory evaluation, and echo also is to be done to the child. Okay, so this is about the follow-up. Okay, so this is all about the management of ovarian carcinoma in the pregnancy. Thank you for your patient listening. And just before logging off, just 1 minute about my app and the Telegram channel. See, this is my Telegram channel where I will be posting if there is any live class, or if there is any free class, and daily protocol will be shared in this. Then this is the Telegram channel, and my app is the Dream app, where you can find. So the links will be in the Telegram channel and it will be uploaded to you. So in this channel you can see the courses, a number of courses where you can have here. This is the regular course 2025, where you will be having so many topics, handheld notes, and everything will be given to you. In the recent advances discussion, where you will be having the more common like these classes, recent advances, and the PYQ discussion, where you will be having the previous years 10 years solved papers, and regarding the classes also 10 years solved papers will be discussed. Okay, and in this app you can see the free material. Okay, so if you see the free material, you will be having the previous year question papers, and mocks will be there, some free videos, and daily protocols will be in this gynec gyan and ops obsession, and the free videos will be discussed here. So follow us for more updates, and if you have any queries you can contact at any of these things. So this is my Telegram channel, this is my number, where you can contact me anytime. This is my Instagram channel, so you can just follow for more updates. So I just want to show you some of the things where yes, since these 2 years we have been teaching the PG gynec people about the theory examinations. Now we have launched for the MBBS students also, and we are having a group where for MBBS theory exams we will be concentrating involving MCQs also, because the pattern has been changed. They are asking MCQs also, so we are trying to go for the MBBS students also, and mock test schedules, everything will be there. Okay, so these are my QR codes and the links for downloading the app. Kindly download for more updates. Okay, so this is the regular course for MS and DNB people 2025, and this is a previous year question course. You can take which whenever wanted, and the classes starts from Feb 4th. Hope you like the video. And yes, we are having a recent advances topic on identification and management of maternal sepsis during and following pregnancy. So this is on Jan 16th. Please be aware of it, and just try to log in. Okay, right. Thank you very much for your patient hearing and happy learning. Thank you.